Hi, welcome back to the channel. Thanks for joining us. Been waiting a long time for this one. Finally, a retinal detachment story walks in the room. Now I don't know if this is vitreous detachment, retinal detachment. It's quite a convincing story. You know, the stars and stripes and flashes. Yep. Bit of blurry vision. A bit of an achy eye, and a little bit of a curtain coming in on the nasal side. So I've never done one of these. I've just looked on YouTube and I've seen them. They look too good to believe. Let's have a look and see. Is point of care ultrasound the game changer? We're in the middle of nowhere. We're 3,000 kilometers out in the Indian Ocean. We have no ophthalmologists within range. We need a diagnosis because we need to decide whether to fly out this poor bugger or whether we just treat him as a vitreous detachment and say, you know, watch him over time. So what I do, I put my setting, I don't have an eye setting on my machines, I just set it to thyroid. One thing about scanning the eye is my understanding is that you don't want to fry the retina. So you don't want to spend a lot of time just putting the probe on the eye and leaving it there. You just want to get in quick, get your picture and get off, unless you have an eye setting that tells you differently. That's just my understanding. I'm not sure how real that is. Just use your linear probe. If I've got it, I use sterile gel. If I don't, I just use normal gel. It doesn't really matter. The eye is not a particularly sterile environment. Lots of gel. And because it's been hard to find a patient, the patient happens to be me. So what you do, I just normally put it on transverse, right? Transversely, just gently on the eyelid, heaps of gel. You'd have the person lying down, tons of gel. You might just use a standoff technique so that you don't put any pressure on the eye. So then you just grab your probe and just gently put it on the eye. The person's lying down, and we'll have a look at the screen as we do this. I've just got it on my eye, just horizontally like that. See how easy it is to see an eyeball. It is just a thing of beauty. You got the lens up here. You got this, obviously the skin. I could do a little standoff. So that's my standoff technique. There's the cornea. If I push a little bit more, and there's the globe. There's the retina there. Probably straight away you're thinking, what's that snake there, right? What is that? And that's what I'm thinking. That's why I think that I can't see on my right eye, I can't see anything on the nasal side of my pupil. You also, just by the way, you get a lovely look at the optic nerve there, and you can look for optic neuritis. That should be less than 4 millimeters if I remember correctly. It's not relevant for this. What is relevant is that this snaky retina that's come off the wall comes down and is attaching into somewhere beside the optic nerve. If it's a vitreous detachment, these will generally cross over and cross over the optic nerve, whereas these are tethered down here, so you always get it sort of tethering in one side. That's one way I know this is a retinal detachment. Well, that's actually probably the main way that I tell the difference, because you do get a snaky thing like this with vitreous as well. I'm only doing one view. I could try and turn vertical. No, sorry, I can't. My eyes are too sunken, so I can't get in there. So I just go with that view, and that's enough. When I sent that picture to an ophthalmologist, that was enough for them to say, yep, you have to come the 3,000 kilometers and get that fixed tomorrow. Then just have the person wipe it off, just get them to do it themselves and blink a few times. So retinal detachment, super simple. If you can scan a gallbladder, or if you can scan a uterus, you can scan an eye, it's probably even easier. If you can scan an eye, you can scan a thyroid. If you can scan a thyroid, you can scan a testis. So these things are all building on each other. It's exciting. Thanks for tuning in. So here's a little bonus follow-up. You know, with ultrasound, you can follow things on a day-to-day basis. I do this with DVTs, you know, calf DVTs, or see if they're extending. You're trying to decide whether to give them anticoagulation. Abscesses that you've aspirated or drained, maybe you've aspirated them, you do another scan the next day, see what's happening. Maybe a fracture, you want to check the position, you just, instead of taking x-rays, put the scan on, see the angle. Turns out you can do the same thing for retinal detachments. You can ask the patient, you know, is their retinal detachment extending while they're waiting for surgery or transport? Or if they're an unreliable person, or you can't be sure about the history, just have a look. And it's a good example, I'll show you. It's 24 hours since we last spoke. Let's see what's happened. Clinically, the curtain has moved across to the midline rather than a quarter of the way across, so we're expecting to see maybe a bit of a change. Let's have a look on the screen. Just see, here we go. Yeah, so there's the optic nerve, right? There's the, lens, the globe, detachment, optic nerve. And I think, well, I'm not quite sure whether that's changed too much at all. That's about it. Maybe it's a little bit more extended this way, I think, towards the optic nerve.